Hello and welcome back to our Wednesday night live session with Dr. Rossi. I'm very excited to be here with you. Whether you're deep in study mode or just starting to map out your preparation for the certification exam, this series is here to give you a taste of what we do every Wednesday night at Clarity Education Systems. So every Wednesday night at 7 p.m. Mountain Standard Time, our currently enrolled students join me for a live session packed with practice questions, detailed rationales, and an open forum to tackle the real questions and challenges you're facing on this certification journey. And because we believe in supporting all PMHNP students, not just our enrolled ones, this video is a free excerpt straight from those sessions. So here's what you can expect. I'll be sharing high-yield practice questions, breaking down the answers with clear, concise rationales, and offering tips to help you think like a pro or a PMHNP on the exam day. This isn't just about memorizing facts. It's about building confidence and critical thinking skills you'll need to pass the exam, and after that, to thrive in practice, which is my ultimate goal for you. So go ahead and grab your notebooks, some coffee, whatever it may be, and let's take a look at your information that you need to know in order to dive in to the certification exam on exam day and successfully complete it. All right, so stick around to the end. We'll also tell you a little bit about how you can join our live sessions and get even more personalized support. All right, that being the case, let's go ahead and get started. Let's jump into our first practice question of this session tonight. It's a good one. So we want to look at the question as it reads. A 33-year-old woman walks into your clinic. She's got a history of migraines. There's no prior psych diagnosis, and she's been feeling off for the last 3 months. She has frequent headaches, irritability, and trouble sleeping. She's been using sumatriptan 50 milligrams as needed for her migraines, but lately she's feeling out of sorts is how she puts it. So you dig a little deeper and you run into the Cage Aid screening tool for substance use. Her score is a 3 out of 4. She hesitates, and then she admits that she's been taking a friend's oxycodone a few times a week for headache relief. Her vitals are stable, and a urine drug screen is pending. So, as the PMHNP, what is your most appropriate initial intervention? Here are the options. A. Provide a brief intervention using motivational interviewing. Refer her to a substance abuse counselor and await the urine drug screen. B. Prescribe tramadol 50 milligrams 3 times a day for pain. Educate her on safe use and then follow up in 2 weeks. Option C. Start Suboxone, order a metabolic panel, and reassess in 1 week. Or D. Recommend ibuprofen 600 milligrams as needed for headaches, start sertraline 50 milligrams daily for irritability, and refer her to a neurologist. All right, take a second to think. What would you pick? All right, the answer is A. So let's break this down and see why this is the best move for you as the PMHNP and why the other answers really miss the mark. So first, let's talk about the Cage Aid score. For those who might not know, the Cage Aid is a quick screening tool adapted from the original Cage questionnaire to include alcohol and drug use. It's 4 questions. Have you ever felt you should cut down, the C is cut down, on your use? Do people annoy you, and that's your A, annoy, by criticizing it? Do you feel, G, guilty about it? And do you have it as an eye-opener, that's your E, to start your day? So a score of 2 or higher is clinically significant. It's a red flag for a substance use program or problem. So our patient scored a 3. That's a loud alarm bell telling us there's a high likelihood of misuse or even dependence on that oxycodone she's borrowing from her friend. So why is A then the winner here? It's all about meeting her where she's at while also setting up for success in the future. So a brief intervention using motivational interviewing, or MI for short, this is gold standard, evidence-based approaches for the situation. Now, according to UpToDate and other credible sources, MI is patient-centered, it's non-judgmental, and it's designed to explore ambivalence about substance use. Now, you might say something like, I hear that oxycodone helps your headaches, but it sounds like it's also causing some stress in your life. Can we talk about what it's been like for you? It's not about lecturing, though, right? It's about guiding her to see the need for change herself. So pair that with a referral to a substance use counselor for specialized support, and you're addressing the issue on hand. So, awaiting the drug urine screen results, that's just smart, right? It confirms that she's been using, how often, if there's anything else that might be in the mix. So the DSM-5 and Kaplan and Sadix both emphasize comprehensive assessment as the foundation of managing substance use disorders, and this approach absolutely nails that. So let's take a look at the other options and why they don't really cut it. So option B, prescribing tramadol 50 milligrams 3 times daily. That should send out warnings, right? That's a yikes statement. Tramadol is an opioid with its own abuse potential. So Medscape definitely notes it can lead to dependence, especially in somebody already misusing oxycodone. Plus, a 2-week follow up delays tackling that cage aid score of 3. We're not here to pour fuel on the fire. We need to put it out. Option C, starting Suboxone right away, that's jumping the gun, right? According to UpToDate and the APA guidelines, this says that Suboxone is for opioid use disorder, but we don't have enough yet. Her DSM-5 criteria for opioid use disorder, they haven't been confirmed, and she's not in withdrawal. So a metabolic panel is fine, but it's not the priority in this situation. Option D, ibuprofen and sertraline with a neurology referral. That's like treating a broken leg with a Band-Aid, right? It ignores the screaming substance use issue flagged by her cage aid score. Her irritability might be tied to oxycodone misuse, not primary mood disorders. And sidestepping that is a missed opportunity for you as a prescriber. So here's the key takeaway in this question. As PMHNPs, we're not just treating symptoms, we're digging into the root causes. The cage aid score of 3 isn't a side note, it's a headline. Option A aligns with ethical, evidence based care, engaging her with MI, connecting her to resources, and gathering more data with the drug screen. It's kind of a holistic approach, right? You'll need to master in order to really excel on the exam and in your practice. All right. So let's dive into our next question here, number 2. It's a real world scenario that you will potentially and probably will face as a PMHNP. So the question reads, a 45-year-old male with history of alcohol use disorder presents to your clinic reporting tremors, sweating, and anxiety for the past 18 hours since his last drink. He typically consumes 10 to 12 beers daily and has a history of one prior withdrawal seizure about 3 years ago. You administer the Clinical Institute Withdrawal Assessment for Alcohol, or the CIWA-AR, and he scores an 18. His vital signs show a heart rate of 115 beats per minute, blood pressure of 150 over 95, and he exhibits moderate agitation and nausea during the exam. As the PMHNP, which of the following is the most appropriate initial intervention? Okay, so here are our options. Option A, administer lorazepam 2 milligrams IM now, repeat every 4 hours as needed based on CIWA-AR reassessment, and then monitor in the office. B, prescribe gabapentin 300 milligrams 3 times daily, provide hydration, and schedule a follow-up in 48 hours. Option C, start naltrexone 50 milligrams daily to reduce cravings, order a liver panel, and refer him to an outpatient counselor. Option D, recommend thiamine 100 milligrams daily, start motivational interviewing, and refer him to a primary care provider for withdrawal management. Okay, you got your answer. The correct answer here is going to be A. So let's unpack why this is the way to go and why the others fall short. First, let's talk about that CIWA-AR score of 18. For those new to it, the CIWA-AR is the gold standard tool for assessing alcohol withdrawal severity. Think tremors, agitation, nausea, anxiety, the works. Scores range from 0 to 67, and anything 16 to 20, like our patient's 18, is going to signal moderate to severe withdrawal. Now, according to UpToDate, the APA, and other reputable sources, this is where things can really start to get serious if it goes untreated. He's at risk for seizures or delirium tremens, especially with that prior seizure history. That's a neon sign blinking at you saying, act fast. So lorazepam, 2 milligrams IM, is perfect here. Benzodiazepines are the cornerstone of acute alcohol withdrawal management. According to Kaplan and Sadix, that backs us up here, noting that they reduce CNS hyperexcitability by enhancing GABA activity. The IM route kicks in quick within 15 to 30 minutes, and this is going to help clutch for somebody that's symptomatic, right? Repeating this every 4 hours as needed, guided by CWA AR reassessment, keeps it tailored. Over medicate and you risk sedation. Under medicate and he's seizing. So monitoring in office, that's about safety, right? With a heart rate of 115 and a seizure history, you're not sending him home yet. You're watching him stabilize. Now, this question could have also said send him to inpatient facility. Maybe would have called the ER, but we can't speculate as to what's going on in the question. We can't say those options are there when we don't know because it wasn't written in the question. Remember, we assume nothing. So we can only use what's in the question and answers. And this is an appropriate response given the information that we have. All right, let's break down the other options. So option B, gabapentin 300 milligrams 3 times a day with hydration and a 48-hour follow-up. No. Okay, gabapentin, um, it's got some off-label buzz or talk about mild withdrawal or cravings, but research mentions it can help with sleep and anxiety. But for a CWA of over 18 or 18 or over, it's too slow and it's too weak. Plus, 48 hours is an eternity when he could be seizing tomorrow. Option C, naltrexone 50 daily with a liver panel and counseling referral. This is also a big misstep. Naltrexone's great for reducing cravings long term, but DSM-5 and APA guidelines say he needs to be detoxed and abstinent first. Starting it in this active withdrawal really could make things worse. So a liver panel's smart eventually, but it's not the priority over his shaking and sweating right now. And then option D, thiamine 100 daily, motivational interviewing, and PCP referral. So thiamine's a must for preventing something like Wernicke's encephalopathy or other complications related to long-term use of alcohol. But for chronic drinkers, that's what it's recommended for. It does not touch withdrawal symptoms, though. MI, it's awesome for later, but with CWA AR of 18, he needs meds, not just a pep talk. And punting to the primary care dodges your responsibility as a PMHNP. All right, big picture here. A CWA of 18 with a seizure history isn't a wait and see moment. It's a treat now moment. Option A hits all those marks: rapid symptom control with lorazepam, ongoing assessment with the CWA, and in-office monitoring to keep him safe. It's exactly the kind of decisive, evidence-based call you as the PMHNP needs to be able to make, and you want to look for those type of answers on the certification exam. Okay, let's go ahead and move on to our next case scenario question. All right, so a 30-year-old male with a history of opioid use disorder, OUD, presents to your clinic reporting nausea, sweating, and restlessness for the past 12 hours after running out of his illicitly obtained heroin supply. He last used heroin 24 hours ago and denies other substance use. You administer the clinical opiate withdrawal scale, or the COWS, and he scores 16. His vital signs show a heart rate of 110 beats per minute, blood pressure of 135/85, and he exhibits moderate tremor and yawning during the exam. As a PMHNP, which of the following is the most appropriate initial intervention? All right, the options are A, initiate Suboxone 4 milligrams sublingual after confirming withdrawal, provide comfort measures, and schedule a follow-up in 24 hours. Option B, administer clonidine 0.1 milligrams every 6 hours, order an ECG, and refer him to an inpatient detox facility. Option C, prescribe hydroxyzine 50 milligrams every 6 hours for anxiety, provide hydration, and reassess COWS in 48 hours. Or option D, recommend ibuprofen 600 milligrams as needed for aches, provide hydration, initiate motivational interviewing, and refer him to an outpatient counseling. All right, so what do you think? What is your top pick here after using the test taking strategies? All right. In this case, the best answer is going to be A. Again, we're going to dive into why this is the best move and why the others don't match up. So, first, the cows with a score of 16, that's what we need to really address here. The cows is your go to for sizing up opioid withdrawal. Think restlessness, sweating, yawning, the whole messy package. Scores range from 0 to 48 and 13 to 24, like his 16 here. This really does mean a moderate withdrawal. So, per the APA, this is a prime time to start Suboxone, but timing is going to be everything. He's 24 hours post heroin, short acting opioids clear fast. So, withdrawal kicks in at around 12 to 24 hours. His symptoms and score confirm his past danger zone for precipitated withdrawal, where Suboxone or buprenorphine, this could make things worse by knocking opioids off receptors too soon. So, starting with a 4-1 milligram sublingual, that's 4 milligrams of the bup and 1 milligram of naloxone, this is going to be spot on for treatment. All right, so according to Kaplan and Sadix, this dose quickly binds mu opioid receptors to ease symptoms while naloxone deters misuse. So, within 30 to 60 minutes, he'll feel relief, nausea fading, tremors calming, and comfort measures like antiemetic or a blanket. That's going to be a good choice for care as well. Following up in 24 hours lets you tweak the dose, maybe up to 8 to 2 milligrams if needed, while keeping him on track for OUD treatment. This is office-based opioid therapy in action. As a PMHNP, you're cleared for it with the right training. Now, why not the other answers? Option B, clonidine 0.1 milligrams Q6. This is an alpha-2 agonist that can dial down sweating and restlessness, but it's a second-line option. It's not as effective as Suboxone for withdrawal or long-term OUD management. So an ECG in this question, this is an overkill unless he's got chest pain or other types of arrhythmias, which he does not, according to the question. Inpatient detox referral for a COWS of 16. That's kind of escalating when outpatient care can handle it at the 16 level. And then option C, hydroxyzine 50 milligrams Q6 with hydration and a 48-hour reassessment. Hydroxyzine, remember, is an antihistamine. It might calm his nerves, but it's useless for nausea or tremors. And waiting 48 hours with a score of 16 is like letting him simmer in misery for far too long. Option D, ibuprofen 600 milligrams, MI and counseling referral. So ibuprofen might dull the aches, and MI is great for later engagement, but a COWS of 16 needs meds now, not just talk. Counseling is a piece of the puzzle, but it's not acute withdrawal management. So here's the good takeaway from this particular question. A COWS score of 16 at 24 hours past heroin is going to scream for that Suboxone. It's fast, effective, and it bridges him from withdrawal to recovery. Option A really nails down that DSM-5 call for evidence-based OUD treatment while keeping him as comfortable and connected as possible. All right, let's go ahead and jump into our next question. And this question reads, a 52-year-old female with a history of hypertension and generalized anxiety disorder, or GAD, presents to your clinic reporting increased worry, palpitations, and difficulty relaxing over the past 2 months. She has been stable on Buspar, 15 milligrams BID for GAD for 1 year. During the visit, you administer the Audit C to screen for alcohol use, and she scores 8. She admits to drinking 4 to 5 glasses of wine most evenings to quote-unquote unwind, a pattern that has escalated recently. Her blood pressure is 145/90, and labs show an elevated GGT of 85. As a PMHNP, which of the following is the most appropriate initial intervention? Okay, so let's take a look at the options available. A, refer her to primary care provider for hypertension management and continue Buspar without addressing alcohol use. Option B, maintain Buspar, start naltrexone 50 milligrams daily, and provide brief motivational interviewing on alcohol reduction. C, Stop Boost Bar, start lorazepam 0.5 milligrams 3 times a day for anxiety, and recommend AA meetings. And finally, D, bump Boost Bar to 20 milligrams twice a day, order a liver panel, and follow up in 4 weeks without further intervention. All right, take a second, pause the video if you need to. All right, so what is your choice? Now, in this case, the best answer is going to be B. We want to maintain Boost Bar, initiate naltrexone, and provide MI. All right, so first, the Audit C score of 8. So the Audit C is a quick 3-question screen for alcohol use. How often, how much, and how often binging. So scores from a score of 0 to 12. And for women, 4 or higher flags a hazardous or harmful drinking pattern. And 8, that's a big deal here. APA says it's well past this kind of brief advice territory, and we dive head on into an intervention that's needed. Her 4 to 5 glasses of wine nightly really does fit that bill, and that elevated GGT, that's really screaming at an 80 that alcohol-related liver stress is occurring. And we are really looking at these numbers. Medscape and APA references are going to be super important here, as well as your local clinical guidelines. So option B really nails all of those areas. Keeping Boost Bar 15 BID is going to help keep her GAD steady. It's a non-addictive, anoxylytic. It's perfect here. All right. Adding naltrexone 50 milligrams daily, that's evidence-based gold for cutting cravings and consumption. The DSM-5 and APA guidelines, they back it. It blocks opioid receptors to dull alcohol's reward, and it also demonstrates that exactly what's found in studies, that it can drop drinking days by as much as 25 to 50%. 20 to 25%. All right, now you might say, well, yeah, but we just talked about this particular drug and how the patient has to be not drinking, ideally for 24 hours. Now, do not add anything to these questions. Remember, we can't insert anything. It just says that the patient, pretty consistently drinks, but it doesn't necessarily say that it was today or last night. So we can't just, we can't put that into the question. We can't just assume that she recently drank. So that's why you kind of throw that out when you're choosing this one as your answer. All right. So starting it in the outpatient is fine since she's not in withdrawal. Okay. Then brief motivational interviewing, that's going to seal the deal for this one. So you'd say, it sounds like wine's been helping you unwind, but it might be stirring up these palpitations. What do you think about cutting back? This is a patient-centered question that boosts her buy-in, and it fits the PMHNP scope to tackle both that GAD and alcohol use together. Okay, so why not the others? Option A, sending her to a PCP for hypertension, and that's really ignoring Audit C scores, right? So that's a fumble here. Her palpitation and anxiety could be tied straight to the alcohol. So, drinking alcohol, it can sometimes and oftentimes will jack up that sympathetic activity. And as PMHNPs, we don't punt that substance use to the PCM. Option C, ditching Boost Bar for lorazepam 0.5 3 times a day with, Alcoholics Anonymous. That again is a big no here. So swapping a safe med for a benzo with heavy drinking, this is a recipe for dependence or overdose. All right, so Alcoholics Anonymous, great long term, but it's not an immediate help that we need right now. And then option D, upping Boost Bar to 20 milligrams BID with a liver panel and a 4-week wait. Now, Boost Bar won't touch her drinking. And a liver panel is useful. GGT is already waving that flag, though. We already have a good indicator in the GGT lab. Delaying action on an Audit C of 8 is too slow for hazardous use. So here's the key takeaway here. An Audit C of 8 with physical signs like elevated GGT demands action. Option B is going to blend pharmacology with talk to address her drinking and GAD without missing a beat. It's the kind of integrated care that you as the PMHNP need to be able to dive into. Okay. All right. Let's dive into our next practice question here. You guys are doing great. So, this question reads: a 38-year-old male with a history of chronic back pain and no prior psychiatric diagnosis presents to your clinic reporting irritability, poor sleep, and recent job loss. During the visit, you administer the drug abuse screening test, or the -20, and he scores a 13. He admits to using prescription oxycodone obtained illicitly daily for the past 6 months and occasionally marijuana to calm down. He denies SI, and his vital signs are stable. As a PMHNP, considering his -20 score of 13 indicating a severe level of drug related problems, which of the following is the most appropriate initial intervention? Okay, so what is your gut telling you here? Most appropriate answer is, in fact, A. So let's unpack why this is the correct answer and why the others just don't work. All right, so first, that -20 score of 13. The -20 is a 20 question. We also have a 15 and a 10 that are out there as well for drug use problems. So think consequences like job loss or failed responsibilities. Scores range from 0 to 20, and an 11 to 20 is the severe zone. So at 13, that's a loud signal of significant trouble. Daily oxycodone plus marijuana plus life falling apart. Option A is going to step up with an intensive outpatient program, IOP. It could have potentially said an inpatient stay as well, which is going to be perfect in this situation. So, IOP is going to offer structured therapy, group support, and medical oversight, typically 3 to 5 days a week. It's intensive enough to tackle his severe substance use disorder like opioid use, while addressing marijuana too. So, ordering a urine drug screen, that's your fact checker. It confirms what's in his system, and it guides IOP teams. This combo is going to align with evidence based practice for severe SUD, keeps him safe, and it fits the PMHNP role. Now, let's knock out those other three here. Option B, starting Suboxone for 1 milligram in office with education and a 1 week follow up. Now, buprenorphine's a powerhouse for opioid use disorder, right? Kaplan and Sadek loves it for cutting withdrawal and cravings. But jumping into that without IOP support for a -20 of 13 is risky. He's got severe issues, multiple substances, and no withdrawal screening like cows yet to give you support in using that medication. It's a piece of the puzzle, not the whole picture. Option C, lorazepam 1 milligram 3 times a day, pain referral, and reassess in a month. Again, hard pass here. So, benzodiazepines in someone with severe SUD, especially opioids, is another huge red flag for misuse and overdose. So, ignoring that -20 score to treat anxiety and punt the pain management delays the real issue here. And then at option D, outpatient counseling alone with a 2 week follow up, that's way too light. A score of 13, this isn't counseling and chill out. It's severe, needing more weekly talks. Inpatient might not fit, but this underestimates the urgency of the situation. So again, key takeaway here, a -20 of 13 with daily oxidone and job loss isn't subtle. It's a call for intensive action. Option A is going to deliver with IOP and drug screen, setting him up for recovery while keeping within your PMHNP lane. All right. So lots of good questions here. That's a wrap for the practice in this session. I hope you're feeling a little sharper, a little more ready to tackle these screener type questions on the PMHNP exam. Now, here's where things get fun in our live sessions every Wednesday at 7 p.m. Mountain Standard Time with Clarity Education Systems. At this point, we would switch gears to an open forum. It's your time to bring anything to the table. Got questions about your semester, something tricky from the review program, stuff you stumbled across in your studies, practice questions tripping you up, or just anything on your mind that you want to talk about. In the live session for our current students, this is when we would do it. And it's a great time to really have a face-to-face, one-on-one, and discuss issues and other concerns about your studies with other students in real time. So we're there to hash it out, right? It's all about supporting you through the journey. And that live link is waiting for our currently enrolled students. right on the PMHNP student portal. So if you're not yet with us, come check it out. This YouTube series is just a taste of what we do in our PMHNP review programs for the on-demand and the live in-person conferences. All right. Before I let you go, I always like to leave you, and I want to leave you with a couple of nuggets of information to carry with you throughout your week. First, from one individual that I love listening to, the one and only Reba McEntire. So she said, to succeed in life, you need three things: a wishbone, a backbone, and a funny bone. So, what do we take from this? Dream big, stand tall, and don't forget to laugh. It'll keep you sane. And then finally, from Robert Louis Stevenson, don't judge each day by the harvest you reap, but by the seeds that you plant. So every study session, every question you wrestle with, you're planting seeds for success. Even if the harvest feels far off, my friends, you've got this. Thanks for hanging out with us today. Please, if you have questions or comments, you can drop them down below. Did these questions work for you? What kind of questions do you want us to practice with on the next session? And then, of course, please subscribe to this YouTube channel for these excerpts each week, as well as ongoing videos and podcasts that directly address the PMHNP certification exam. For our current Clarity Education students, I'll catch you Wednesday night next week. Make sure to bring your questions. All right, to end, here are references for tonight's session. And please take care and keep pushing forward in your studies. Again, this is Dr. Rossi with Clarity. Bye-bye.